Hey, it's Jeremy Faust, editor-in-chief of MedPage Today. We're going to dive into Season 2, Episode 2 of The Pitt, my reactions as a practicing ER doc. Let's take a look.
Ma'am, this is a teaching hospital. Is it okay if some of our trainees join me?
Not a problem.
Dr. Whitaker, Javadi, Ogilvy, Joy. Gather around. Dr. Langdon, you are more than welcome to stay too.
Maybe for a minute. We're pretty busy in triage.
Okay. Stevens, I have an app on my phone that can listen to our conversation and the details of my physical exam and write it all up in your medical record.
Wow.
It's protected.
All right, I'm just going to say that we have been rolling this out, and the reaction from students and residents when we first started doing it was very similar. They were very impressed and excited, and we told them, you cannot have this. This is for attending level to begin with. It's important to learn how to document medical documentation without that AI assistance. But I will say I've been using it for a year now, and I do like it. And the patients almost always give permission. I occasionally will not ask in certain situations just because it seems like the wrong time. But it is something that I have found really useful.
Dorsalis pedis and posterior tibial pulses 2 plus and equal.
So she's documenting, and the thing is listening, so that actually for the physical exam part of our note, it will say what she just said. So nice to not have to document that, must tell you.
Your exam is perfect, ma'am.
Oh, that's good to hear.
I will be back when your blood tests are ready. Let us know if the chest pain returns.
Thank you.
You are so welcome. What do you think?
Well, I don't think it's cardiac.
I mean, what do you think of the app?
I mean, it's hard to say without seeing the full thing.
Take a look.
Oh my God. Do you know how much time this will save?
Again, I had the same reaction when I first saw this thing.
Studies show you can spend 80% less time charting.
All right, so in the emergency medicine literature, we're not quite seeing that. But in fact, we just published, we just saw in the Annals of Emergency Medicine, it saves some time. And actually, in some cases, we're spending more time in the charts early on because there's some onboarding, learning how to use it, and editing. But again, I find that even though I'm not sure it's saving me time yet, but it's just, there's something about having that framework there so that if I come back hours and hours later, I don't have to remember everything. It's easier to sort of like have your memory jogged by what's there than have to rebuild it from scratch hours later when you're charting.
Get out of here sooner, improving both patient and physician satisfaction.
Oh, excuse me. It says here she takes Risperdal, an antipsychotic. She takes Restoril when needed for sleep. So is that,
AI. Almost intelligent.
Generative AI is 98% accurate at present.
All right, so it's true that we also make typographical errors. We also make errors when we're dictating, just using a regular dictation. So she's correct that it's not quite fair to compare what's going on here to perfection. On the other hand, I do think that sometimes the AI will make a bigger mistake and you really have to be on top of editing it.
You must always carefully proofread and correct
Like she said.
the minor errors. It's excellent, but not perfect.
This is amazing.
All right.
Dr. Rabi, is this a good time?
That depends on what you have in mind, Dr. Alashimi.
I'd hoped you would have reviewed my ideas for improving the department. I was looking forward to getting some feedback from you.
Okay, well, I think the department functions pretty well, all things considered. I mean, we face the same challenges that most emergency departments face.
Let's take generative AI, for instance. ER doctors spend 40% of their time charting, only 28% of their time at the bedside.
That doesn't sound accurate.
I've included the study in my packet.
Right.
And patient passports have been shown to increase satisfaction because they show the time required for
Yeah,
each
I got it.
phase of the visit.
I'll just say that Dr. Rabi is expressing something that I think a lot of doctors are surprised about, which is how much time we spend in front of the computer versus with the patients. I agree with her. I think we spend a lot of time away from the patients, and it's probably less the case in a trauma center like the one that they're dramatizing here. I work in a trauma center as well, but the more trauma you work with, the more acute care you work with, the more time you spend at the patient bedside. Overall, I think that documentation using AI is something that's here to stay. I think it's going to get better and better. All right, let's go up next to this next clip.
I'm not sick.
oh, we took care of your husband, Ethan, earlier today.
Is Ethan sick?
Well, he was very ill. And we did everything we could to treat him, but his heart stopped beating. And I'm so sorry to say that he died.
So let me just stop here. What a tragic situation this is. This is a patient with dementia herself, and then this young doctor is delivering this news to her. I would just say that he actually, given the situation, does an incredibly good job here. He doesn't do a lot of backswing, meaning he needs to tell her quickly what it is that happened. You have to really set this up quickly and then get to that news very, very, very quickly. And he said the words, he died. He did not say he passed or he didn't make it. He said he died. And it's really important because we think we know what words mean, but if you say he passed away or he passed, what? He passed the test, he passed into the next room, what does that mean? You have to say very specifically what happened, and let's see what happens next.
Died? Ethan? No. Are you sure?
This is absolutely classic. Just the words no, repeated no. There's just that disbelief, and it just doesn't seem to be possible. And even for patients and their families for whom it is not a shock. I mean, you'll hear that same sort of no, that denial, that can't be true, said about patients who were on hospice. I mean, it's just the human brain just does that. We have a very difficult time accepting news like that, and that's just part of our species.
Yes.
No. Ethan isn't sick. No.
I know how difficult this must be for you.
Yeah. I mean, we do have to sort of bear witness to this. And I will say also, this is a little bit more extreme because she's also a patient at the same time, and she has dementia. This arc moves forward in the episode, and unfortunately, she doesn't remember at least one time, if not a couple of times, that this occurred. And that's another level, which is how do you deliver news to someone who's not necessarily encoding memories? So again, I give a lot of credit to the writers here for confronting a typical but difficult part of our job. Do want to spend a couple of minutes with a couple of smaller little things. Again, just the sort of accuracy of the show and what it is we do in emergency medicine. Let's take a look at this clip.
You ever used a cast saw before? Of course you haven't. Well, today's your lucky day. Follow me. Dr. Mohan, you got a minute?
Yeah.
Have you met Emma? First day, new grad RM?
Hi. Nice to meet you.
Emma needs to learn cast removal.
How long's the cast been on?
Months, maybe years. Probably gonna want to breathe through your mouth. All right, Mr. Digby. Dr. Mohan can cut your cast off now.
How long's the cast been on?
I don't know, but it's really getting itchy.
Okay, this cuts the cast, not the skin. This should relieve the itching.
I'm just going to say that is such a good representation of a conversation that we have all the time. It is so hard for people to see a circular saw coming at them through a cast and not think it's going to cut them. And so Nurse Dana there demonstrates on herself that the saw will not cut through skin. It is an amazing piece of technology. This is not going to go well.
With the cast spread.
Thank you.
You can just tell that cast is very old, and so we're going to see something like an infection underneath there, something bad.
Oh, I see you brought some friends.
Oh my God, are those maggots?
Yeah, wouldn't be the first time. So in this case, not infection, in this case, infestation. very, very common when you put a cast on a patient who doesn't necessarily have housing or follow-up. There is this risk. So this is someone who you might have thought maybe they should have a removable splint to begin with. And so the cast is the best thing for what he had probably, but there's just every patient's different. What's best for you and me may not be best for the next person because complications like this have to be considered.
You all right, Dr. King?
Yeah.
You don't seem all right.
Well, my deposition is today.
Do you want to talk about it?
I'm not allowed to.
No, we don't have to talk about the deposition, but we can talk about how it is affecting you.
Okay, this could only be written by real doctors. It's so true that medical malpractice and depositions are so stressful. Of course, we've covered this in MedPage Today and elsewhere, that just the emotional toll it takes, even if the doctor or other clinicians feel that they've done nothing wrong, it is such a weight to carry, and I think it's very difficult to work the same day as a deposition.
Average emergency physician catches a med mal case every 7 years. 9 times out of 10, the doctor wins. I've been sued 4 times myself. Dr. Al?
I've never been named in a lawsuit.
Anyway, he's correct. The longer you practice, the more you practice, the more likely there is to be a lawsuit. And some of them are legitimate, some of them are not. But what's unarguable is that everyone's doing their best job, and it can really have an incredible impact on wellness for clinicians. And it's just, I think it's amazing that they've decided to pursue this on this show. So hats off to them for that.